thank you everyone for making it to the final panel of the day. And I'm sure you're all feeling energized by the speech from the Minister. We're now going to finish off on talking about hospitals to community with this esteemed panel. So to my right, I have Nico Reynders. Have I said it correctly? I asked you, we were discussing it just before the panel, and I've now suddenly forgotten how to say your last name, but I hope I said it correctly.
Totally fine.
And Kirsten Waters, who joins us from Camden Council, specialist in public health. Alec, Dr. Alec Price-Forbes, who joins us from NHS England as the National Chief Clinical Information Officer, and Dr. Minal Bakhai, who joins us also from NHS England as the Director of Primary Care Improvement and Transformation. So lots of brilliant minds that can help us unpick the slightly amorphous concept of hospital to community. Indeed, when I started out in health policy a year and a half ago, when I started at Restate, I ended up almost pulling my hair out trying to figure out what on earth community meant. I think it means everything to everyone. And as if any of you have read my article in the brochure today, you'll see me talking about that it means, and it still does mean, you know, primary care, it means social care, it means district nursing, it means mental health. And I think that if there's one thing we've learned from the panels today, it's there is a chronic ambiguity as to what it actually means in reality. And that often ends up being quite a significant practical obstacle to delivering the elusive shift towards the community. And it'll be interesting to talk about it, having followed a brilliant sickness to prevention panel earlier, thinking about it through the more institutional lens of hospital to community. So I'm delighted to have so many interesting people here to talk about it. So let's get straight on to opening remarks. So Nico, I'll go to you first.
Thank you, Rosie, and thank you for the invitation. Hi, everybody. I'm a little bit nervous when you call us brilliant minds because it puts the bar at a place where I don't feel comfortable anymore. But I'm Nico Reynders. I'm the general manager for UK and Ireland of a company called UCB, which maybe you know, we're a quite a big investor in something which this country is so fantastic in, which is bringing scientific knowledge to the foreground. And so we have in a little bit down the road in Slough, we have a fantastic research lab of about 800 scientists. And we, of course, also commercialize medicines across the whole world. We're also a very proud sponsor of this conference. And I think the name is a very interesting and a very intriguing name because it talks about the reimagine health. And that has two parts in it. One is a very, very positive part, which is imagine. Because it makes you dream. It makes you able to describe where we really should be in the future. And I think it's great to have that mindset ahead of us. At the same time, there is the re before it. And the re before it kind of implies we have to redo something. We have to change something. And I think we can collectively say that's also really true. And that's okay. That's okay. It makes it interesting. And I think Minister Kinnock talked about a lot of interesting things, which I'll only focus on one of them for now. He spoke about demand management. And I think that was a very important angle because, of course, there is the solution at the end in the community, but there's also how do you manage the demand up front, upstream? How do you not just lift and shift without really changing something? Because if you lift and shift something from the hospital to the community, but you don't make the service better or different, I'm not sure it will actually have any impact either way. And I've had the luck in my life to contribute or to work in China and to work in the US. You might be surprised that actually in China, the community aspect, the closer to home, as I would define it, aspect, is something that works quite well. And that is quite interesting. And maybe there are some nice examples to learn from there. So, but my key message to start from what Minister Kinnock said is this demand management, this upstream management is, I think, very important before we can move into something that I support wholeheartedly, which is bring care into the community. But thank you, Rosie.
No, thank you. Kirsten, do you want to bring in some insights from local government, which has been a frequent feature of all of the panels today, I would say, which is very positive.
Yes, I think it's very welcome. I mean, I think there's consensus that, you know, community care is everything but hospitals, which I'm not sure helps that much. So I've been thinking about, what are the principles of community care? And for me, it's definitely place-based. So it's very much rooted in communities and in place. Now, I think that works very well from a bottom-up perspective. I think it makes it quite a complex operating environment when you're thinking about providers over large geographical patches, and how do you work in a place-based way over quite complex and diverse geographies. So I definitely think that's a challenge. But for me, community care is place-based because it's able to utilize community assets in a way that we haven't been able to do before, or we haven't been able to do to the degree that we've wanted to do before. It's also population focused, and I think community-based care has to be whole population based and focused. I think some of the policy emphasis on just looking at long-term conditions or older adults is really not being able to maximize our preventative agenda. So I think the aim of community-based care is really about not just a left shift, but it's depressing the demand curve. And to do that, we have to look at whole populations. So for me, what does community-based care look like in the future for different groups? And I was talking at lunch around with a colleague from the Nuffield Trust, what does it look like for children and young people who we know actually we're seeing rising long-term conditions, admissions and management? Do we have as clear a vision for those groups as we do for others? So whole population focused, definitely around personalized care. And I think if we are here in 10 years time, we'd have made huge strides in personalized care. And actually, how can we utilize population health management approaches through ICS to really maximize personalized care from both a prevention aspect and looking at different degrees of patient activation, to also looking at more acute ends in terms of some of the digital and tech aspects around wearables, etc. So there's something around the personalized care, and absolutely it has to be preventative. We spoke a lot, panel spoke a lot about prevention earlier. But for me, the prevention agenda within community-based care, again, has to be whole population, whole pathway. I think we can maximize our prevention approach through community-based care in neighborhoods. So, for example, whether we're looking at pathways, for smoking cessation to cardiopulmonary rehab, we don't have that sort of strategic coherence across a lot of our preventative programs at the moment, partly because they're quite unintegrated in terms of providers, but also the actors within it. So there's something about, I think, maximizing efficiency within that. Very briefly, I think some of the challenges that we'll all agree is data, so integrated data sets, diagnostics and estates, and I'll probably add workforce as well. Particularly, I think groups of workforce that we really need to pay some attention to. I'm going to say school nursing, health visiting, practice nurses, district nurses as key elements, I think, of community workforce we really have to have a long-term workforce strategy for. And then finally, it's very, you can have a world-class community health service, but if you're not in healthy communities, then it's going to have limited impact. So again, it's bringing in local government and looking at wider determinants of health. Locally, some of our virtual wards, our ambitions around virtual wards have really been impacted by the way that people live, in damp houses, cold houses, on their own. We can't have virtual ward and maximizing care at home if we don't have that kind of infrastructure. And increasingly, particularly, within urban environments, the housing where people live is not conducive to their health and well-being, particularly if they're needing additional care. And also then finally, the additional care demands that community-based care may have. What's our future strategy for our care workforce? And that's both qualified and unqualified care workforce. We need to be able to think about these things too. And then finally, I think there's huge potentials for neighbourhoods and neighbourhood working. I think that they are both a concept around integrated personalised care as well as just a place. I see the ambition around really looking at the devolution of healthcare policy, but also really rooting healthcare delivery and public health in communities has huge potential.
Thanks so much. That was super interesting. Just to quickly bounce off some of that, I think it's such a good point you made about hospital at home and virtual wards. In our recent paper, we did a big deep dive into those models, and they are astonishingly effective and efficient. But like you say, lots of people actually prefer being in hospital. It makes them feel more comfortable. There's a lot of systemic problems that, like you say, around housing that can't be fixed until those can be scaled until they're fixed. But on the neighbourhood point, what would you say are the major obstacles to actually finally achieving the kind of proper, comprehensive neighbourhood health systems? Like, is it a funding problem? You know, we look at general practice in 2023. General practice got about £9.7 billion for the entire country. That £1 billion, over 10% of that budget, could just go on one trust. You know, the quantum of money between the two systems is completely different. Would you say the big obstacle is money, or is it actually more people or workforce or what have you?
I mean, more money is always welcome. But I think it's quite a complex landscape of delivery, commissioning, contracting. You know, just if you look at, you know, within, you know, London, you know, numerous local authorities, providers, community groups, primary care, it is quite an unintegrated system of delivery. I think we do need to be able to look at simplifying the landscape. I think the role of integrator organisations has a lot of potential. I think there's been a lot of discussions, you know, locally, regionally, around what is the role of integrator organisations, who should be the integrator organisation. My own personal opinion, it doesn't really matter which organisation or which part of the system, but their key role is helping others work together. So I think really focusing on how as a system we work together and looking at some of the key barriers to that. Now, some of those are financial, some of them are cultural and organisational, and some of them because we operate in very different decision-making landscapes between local government, provider trusts and ICBs. So I don't just think it's money, I think it's slightly more complicated than that.
Yeah, brilliant, I'd agree. So Alec, it comes up consistently in people's reflections on hospital to community sickness prevention, the role of data and information, and the kind of potentially transformational role that could play in becoming a more preventative healthcare system. Did you want to speak a bit more about that from your position?
Yes, thank you very much, Rosie. Well, I think if we're going to have an NHS that is fit for the future and able to enable those shifts to happen, and I think, by the way, that the shift of analog to digital is just a given, and it's not just digitizing what we did on paper and broken paper processes. It truly is reimagining care delivery and reimagining the location of care. Then we need to make that seismic shift, and that's going to require investment. So we're delighted to get 10 billion that's been ring fenced. That's a 50% increase on the 25-26 funding that will ultimately improve public as well as patient satisfaction and staff experience set against the efficiency and productivity gains that we need to deliver. We know the Darzi investigation has highlighted that we're in the foothills of digital transformation despite the billions that has been invested over the past 10, 15 years, primary care being far more advanced than secondary care, but nevertheless, we still have challenges of siloed, fragmented data sources that are incomplete, inconsistent, and not continuous. So we've had 76 years of development of the NHS, you know, transforming society with technology, and medicine has transformed, so we're all living longer. But the problem is we're living longer with chronic disease burden. We are now living with chronic diseases that hitherto people would have died from before the Second World War. So we've got to reimagine. We've got to reimagine the operating model for health and care, and that requires reimagining the digital and data architecture that supports the core things that happen a million times every 16 hours. When somebody with a problem, be that a health or social care problem, is being seen by a health and care professional. And it's critical to just enrich and add value to every single interaction, but to allow data to flow. I'm going to sound a bit nerdy now, but anybody a Whoop user in the room? Well, I'm the only one. So I've now got the medical grade device Whoop. It's continuously monitoring. I'm delighted to share that my biological age is 6.5 years younger. So I'm trying to live by and set an example by my experience. But all the data that's being monitored on my heart rate variability, my respiratory rate, all of that stuff would be very useful if I became ill. But right now it resides within my phone in an application. And it doesn't go anywhere. It's not actionable data that if I presented to Minal in primary care, or if I presented to ED, God forbid, with a heart attack or stroke, they would see that my resting heart rate is normally 47 and that my heart rate of 80 is probably within normal limits, but not normal for me. So how do we create actionable data that provides insights, that enhances how we do things, and really reduce the pain points and the restrictions for our staff? So I think digital and data will be a focus as we try and focus on prevention. and population health management, as well as strengthening care in communities and further advancing diagnostics. And I think it's going to be really important over the next 10 years with the 10-year plan that we move from a disease service that treats patients, reacts and responds to people, to truly a health service that predicts people at risk and curbs the demand. We are not pulling people out of the river of disease, but we stop them falling in upstream in the first place. We tackle health inequalities, and we make the digital just secure and safe and user-centered by design, that we give patients a personalized and proactive experience. We create the single digital front door of interacting through the NHS app. Some really exciting stuff going on now with that. With 51 million users, there's 7 million repeat prescriptions every month, and 18 million notifications sent out this month in April, compared to only 9 million last year. So notifying, reducing the paper trail is going to be incredibly important, and it will improve decision making and efficiencies for staff, being able to see people in the right place. So I think it's important to reflect that if we leverage technology in this way, we are going to truly empower our caregivers, as well as those providing care, to actually really fundamentally shift the way we deliver care. And the final reflections, we have care in 3 places, and I think we sometimes forget this. So either you are too ill to go anywhere and you're in your own home or a care home, or you're too sick to be cared for in your own home and therefore you're in a hospital. And that's what hospitals should be for. As a chronic disease specialist, I'm no different to what Minal does. And that's the middle section, which is community or ambulatory care settings, which is everywhere else. And that's where we need to focus. And my final 3 reflections. One is, a year ago today, I started a vigil sat next to my mother, who was dying in a hospice. She died a week later, so next week, when I'm on holiday in Greece. She was cared for with dementia, with deterioration over a 5-6 year period, by an incredible faith-based nursing home. And I think we need to call out, we've heard some reflections on social care, and I'm absolutely clear the NHS is not the answer here. We need to be focusing on the wider social determinants that really impact people's lived experience to make it as good a life as possible. My mum had an amazing death, but the NHS, strictly speaking, had nothing to do with it, because I was really battling to avoid her being taken in an ambulance to an A&E to die. The second reflection is my son, as a consequence of that experience, age 15, lost all his hair. So it's been a pretty challenging year, and I've had the real value of not just being a clinician, but being a dad, experiencing the experience that our patients get. He's on biologic treatment now, immunotherapy, to try and bring his hair back. Hasn't worked. That's another story. But the challenge of trying to get investigations done and to get that repeat prescription is a complete diabolical nightmare, because I can go on Amazon yesterday and something has already been delivered for him today to recharge his phone. Trying to get blood results, even in the NHS app, 3 weeks later, are still not there. We've had to get them through a manual process. Getting a chest x-ray took 4 weeks. I'm a consultant. It's really easy for me to request those, but this is the real lived experience of the public. And the final thought is, I will be going home tonight. Today, Monday, is a clinical day. I'll be doing a virtual clinic tonight when I get home. I pioneered video consultations 9 years ago. I pretty much stopped doing them to a degree because it's not integrated into my workflow, having to go into a separate app, and patients aren't used to the different apps they're having to navigate for virtual health and care. So we need to get that right, but the technology exists. The real challenge is people, because I'm one of 9 rheumatology consultants. I've done more video consultations than any GP or secondary clinician in Coventry and Warwickshire, because I've got the data. But I've stopped doing it, and therefore nobody else is. So we kid ourselves about virtual health and care, but we need to move to that sort of model. And to do that, we need the enabling digital and data architecture to support it. But most importantly, we need to invest in why my 8 colleagues don't do it. We've got to make it easy, but we've got to change the culture. As culture eats strategy for breakfast. And until we start investing in people and change management, we're not going to realize and harness technology revolution that has transformed all our lives in every other sphere.
Thank you, Alec, for that extremely compelling and personal telling of your experience with the NHS. I have a million questions off the back of it, but quickly, I just want to bring you in, Nico, particularly around the role of data and the intersection with life sciences. how do you find it from your perspective? What the kind of data architecture of the NHS, how does it make your job, I suppose, in some ways much easier or much harder?
I agree with Alec that there is a massive opportunity on data that we can get better at. The NHS is sitting on a massive amount of data that should be used to investigate how patients could get better, that could and should be used into our research. And today that's not happening yet. And I think that's an opportunity as well. And I want to, now that you gave me the mic, I want to build on one thing that Alec said, because you talked about the middle section. I think there is another middle section that we should look at. Because you talked about treatments, and there are a lot of, if you want to think about the part of reimagine, where I do think in the UK we have to think carefully on how to bring people from hospital to community, is on making the right treatments available for those patients that need it. And that's a sentence that you need to look at as a whole. Not treatments for everybody, but treatments for the patients that need it. And I'm just going to shout some data, some numbers to you. If you happen to be born in Germany, 88% of all medications that have been regulatory approved actually get to patients. That's a pretty good score, 88%. Does anybody know what the number is in the UK? Because in the UK, the number is 54%, which means that if you have a daughter or a son or a mother, or in my case, I lost my father last year, and you have a certain disease, there actually is 34% less chance that the right treatment is available in the UK compared to other countries. Now, we can look at that from a data perspective, or we can look at it from a human perspective. Because if you're born somewhere, it's not your choice. And if you have a certain disease that is not because of your own behaviors, you also don't have a choice. And I think that's something we have to fix. And to me, that's part of the
Completely agree. And Alec, one thing that's come up in a lot of our research when it comes to data, it's not just the infrastructure, which I think, like you say, there's a lot to be done in just getting the basics right. But when we did some work on primary care last year, we found that integrated care systems, they don't really have the staff to do the analysis. You know, the analytical capabilities exist, but they're not in the NHS. And where they are, they're not really being used for kind of long-term reimagining of the local health system. They're being used to do short-term, mostly focused on emergency care, really, to look at the volume of patients in the system and things like that. What do you think about how the NHS can attract more of that kind of advanced analytical capabilities that can do a lot of that heavy lifting, assuming that the data architecture eventually comes in as crystallized in all of the ICSs across the country?
Okay, great question. I mean, assuming you've got high quality data, then AI could do that for us. So the question then is what those people are going to be used for in terms of interventions, because I think that's the more key. It's not just having the data and being data driven. It's how do you actually intervene to use that data to be a learning health and care system where you're improving outcomes for people. I think we are now, obviously, you know, it was referenced by Minister about the re-engineering of ICBs, and model ICBs, and there's been lots of concern around the digital function and leadership. It's not just digital leadership, but leadership more generally within ICBs. So working on model region at the moment, but I think there's going to be a really key bit as we get the 10-year plan of how we start to, it's not just about how we really architect the digital and data, it's how we leverage people. Not just those who deliver care and need to use these systems if we're going to get the benefit, but how we leverage that the strategic capability to actually deliver interventions, to equip the workforce with those, to use the insights you get from data. And I think we need to construct that. I think that's work in progress, but it's absolutely key that that's where you need to devolve, I think, to start looking at neighborhoods, start looking at the voluntary and community and faith and social enterprise sector. So you really start to focus on those, that 30 to 50,000, depending on the geography of your neighborhood, to really start to leverage with local authorities and wards how you impact on people. We know that, as I said, 10% is healthcare. It's all the other stuff. It's the communities. And what I observed in my own experience of having been, you know, homeless when I was born, my mother was white, my dad was Indian, I've never known him. So single parent in Norwich growing up in a council flat, eventually having been homeless for 18 months, it was the community and the faith community that supported my mother. who came to the fore in the last few years of her life. And I think that's so incredibly important, because that's where healthcare resides. How we make changes is around the communities that often we see it spring, don't we? When national tragedies happen, we see communities being the key thing. How do we leverage that asset that sits there? You were talking about community pharmacies earlier. There's so many out there, and I think we need to become digitally enabled and data rich and use those insights, but it's the interventions that require people living in the neighborhoods to make a really big difference.
Yeah, I think that's a really brilliant point, and has actually been brought up multiple times throughout the day, which is goes to show there's some consensus on it. So Minal, I'll come to you now. Obviously Thursday we've got the 10-year plan coming out. It's long been expected it's going to major on neighbourhood health. No small task for you, running primary care transformation out of NHS England. So do you want to, enlighten us with some of your remarks as to what you see the next few years looking like?
Yeah, I'm also a GP. I'm a GP in Harlesden, Northwest London, so the second most deprived ward in London. And I would say that we have been doing neighbourhood working for about 7 or 8 years now because of the pressures. My patient population have a 15-year difference in healthy life expectancy compared to a few miles down the road in Chelsea, Kensington and Fulham. And actually, it's been a policy ambition to move care closer to home, move to more preventative, proactive care for about 5 decades. That's 50 years. And I suppose one of my key reflections is, instead of seeing that left shift, we have seen this right drift. We have seen hospital funding grow by about 21% over the last decade. We've seen community funding grow by 4%. We've seen workforce expand towards a more specialist skilled workforce. So growth in hospital consultants by 168% over the last decade, a 7% reduction in GPs, and a whopping 50% reduction in district nursing. We see medical research and innovation, again, centred around the hospital. And actually, what's really interesting is that when you look at the growth in elective activity, 50% of that growth is attributable to advances in innovation, not due to changing demographic need, as we see in primary and community services. And so we have a systemic bias in the system, our systems, towards hospital-based care. So it should be no surprise to any of us when we look at graphs of unscheduled emergency hospital admissions, while we see a small increase in growth due to the changing demographic need, natural growth, we see an exponential increase in avoidable and modifiable emergency admissions. And that is related to a disinvestment in primary and community services, and really importantly, community infrastructure, those social assets that strengthen communities and in particular address those wider determinants of health. We know that we are going to see we know that in the next decade, 68% of over 65-year-olds will have multiple long-term conditions. We're seeing rising rates of long-term sickness in our working age population. We're already spending 41% of the public sector budget on the NHS. The statistics go on, but essentially they all point to the fact that we cannot continue like this. It is unsustainable, it is unaffordable if we continue on this route. And so for me, this is no longer about the coalition of the willing, it's about the coalition of the determined. I have the privilege in my role to go visit lots and lots of places that are progressing neighbourhood working. The challenge is spread. So I see lots of maverick leadership that has really driven this approach. They've driven a left shift because of the trusted relationships, the permissive culture, and the shared outcomes that they have developed. But that was in spite of the system. They basically ignored everything the system told them to do and then did the right thing. And so it's how do we move to a place where we start to systematize that? And as I've been visiting lots of places, I've been trying to distill down what are the key change principles that have enabled them to see the success that we would like to see across the rest of the country, because they have seen reductions in emergency admissions, in A&E attendance, in general practice use, improved patient well-being, improved engagement with their health and well-being, so screening activities, immunisations, And three key things stand out for me. So while they've all implemented very different interventions, and I think that's really important, the interventions are hyper-local, they are designed around their local population and communities. They've all centered around having a named, multi-professional, multi-agency team wrapped around the community or the neighborhood. That's supporting them with both proactive and reactive care. And I should say it's not just person-centered, it's household-centered. The second is strengthening community-led initiatives, investing in social assets, and driving forwards some of the things that matter most to communities, what would make their place a healthier place to live. And then thirdly, it's about activating the resourcefulness of individuals themselves. So patient activation, supported self-management, co-management, particularly of their long-term conditions, but actually more broadly of their health and well-being. And I could go into lots of details around some of the brilliant work that I've seen. But fundamentally, if we want to see this radical shift, we absolutely need all of the enablers that have been described by colleagues on this panel, but we need to be able to systematise this large-scale change. And so I'm leading the National Neighbourhood Health Implementation Programme, which is a large-scale improvement programme or change programme. Essentially, it will cover the whole country. So it's not about exemplars, it's nationwide. It takes a tight, loose, tight approach. So we're tight on a shared mission. We're tight on a common approach to a way of working, cut out the bureaucracy. The F word in our neighbourhood, forms, have disappeared thanks to some digital solutions. And then tight on the outcomes and actively learning, not just within our system or place, but from places around the country. And then essentially having that flexibility to deliver, to adapt in a way that suits your local population, but cultivating the right capabilities, the right leadership, and I stress leadership, place and system leadership, not organizational leadership. And the enabling structures, the backbone infrastructure that you need to be able to do this. And it is truly inclusive. So while I'm a GP, I work in a team with local government, third sector, social care, and the governance for this programme is equally reflective of that. And it's really important that through this programme, we start to surface the barriers to change. So one of the biggest lessons learned from previous large-scale change programmes, if you look at programmes like the Vanguard's programme, were that they made incredible progress on the ground, but the pace of change nationally could not keep up with the pace of change locally. And then it became too hard because policy, contracts, whatever it was that was needed, didn't change quickly enough. So it's really important that we embed those rapid feedback loops through this programme, giving it teeth. And some of my colleagues, Nick Hicks, I'm just going to call him out. If you want to talk about funding flows, find Nick. He's leading our enabling steering group on funding flows, but we've got one on digital and data, workforce, and estates as well. And really that is to try and cut through some of the challenges and lessons learned from previous work. And if I ask those places now, what are the three most important things to you around neighbourhood health, or that have enabled you to embed neighbourhood health? And I think it's just worth calling out, it's not a model, it is a way of working. They would say to me, it's not about community being part of the solution, it has to be the foundation. The second thing they would say to me is a permissive culture. So having the flexibility to go and do what's right, to take positive risk. And then the third thing they would say is that we have to hold everybody to account for population health outcomes, and in particular, the outcomes that matter most to communities. So patient-reported outcome measures. And then I was talking to Nick on Friday, and he taught me this, so it's all down to him. But he taught me about the entrepreneurial gap and the fact that if you create outcomes that are not in somebody's direct sphere of influence, i.e. You need to improve somebody's job prospects or their housing or their social connectedness, then it forces people to think differently, radically differently, to formulate new partnerships that can then drive innovation and creativity. But I think fundamentally, we all have to be, as a priority, responsible individually and as organisations for population health outcomes.
Hey. That was extremely comprehensive and thought-provoking. Thank you so much. And before we open up to audience questions, I just want to draw attention to something that I think every single panelist has brought up, which is the C word, which is culture. It seems that everybody highlights this as a barrier consistently in the shift to community. And it seems to be, I mean, universally across every industry, business, public, private sector, culture is fundamental to how an organization operates and the outcomes it achieves. What would the panel say about, steps you can take to actually improve the culture that creates the permissive culture that enables the shift to community? Because we see it all the time when we talk to people in hospitals that there's so many different cultures that perpetuate all sorts of different behaviors that undermine good outcomes at every part of the health system. So how would you all tackle and suggest that the government or any sort of intervention is needed to tackle this cultural problem? Who wants to go first with that very difficult question? Minal?
Yeah, I'm happy to start. So I think firstly, it's about a mindset shift. So we have to move away from body parts to whole person care. So it's from a medical model to a biopsychosocial model. I think the second bit is from a deficit-based approach of, what's the matter to you? What's the matter with you? To thinking about actually what support do you already have? What are your strengths with a strengths-based model? And that's what really drives those community-led initiatives. I think it's fundamentally valuing relationships. So at the moment, if you ask me as a GP, my targets are all around appointments. So how many people I see, how many consultations I do. Now, as I said, I work in a very, very deprived area. Lots of people are not engaged with the healthcare service. When we were, during COVID, I would spend an hour individually, one-to-one, on the phone with my patients to build those trusted relationships, to help them then trust me to engage, to come and have their vaccinations. Now, I would look like the most unproductive GP on the books, but that's because we don't value relationships and time to build those trusted relationships. This does not work without relationships. You can throw contracts at it, money at it. All of those are very, very important to align, to create the backbone infrastructure to sustain it, but it does not create it. The creation is, if you ask anybody working in a neighbourhood health service, they will say the biggest, most important factor is trusted relationships. So we've got to create time and headspace for people to build those relationships, to have those multi-professional, multi-agency meetings or opportunities to get together, to work together, to talk to each other. And we have to remove the barriers that enable them to do so. And that requires trust and permission. So I think for me, this is a leadership revolution. This is about letting go. It's about trusting. It's about partnerships, and it's about valuing relationships.
Can I come in?
Of course, Kirsten.
So someone who did all their training in the NHS and then qualified as a consultant and immediately went into local government, the two organisations are quite different. But I think purpose-led leadership can bring them together. And I think that hospital chief execs, ICB chief execs, and future chief execs of local government should have a sort of shared purposeful leadership. And I think there is nothing like understanding a different organisational culture and perspective than going to work in it. So I think there's something around how are we modelling future leadership development across sectors. And I think that's around the purpose bit. Is the purpose of, system and chief exec leadership for whichever organization you're in, is that about sort of, financial stability, servicing, some part of the system, or is it really about delivering outcomes for population? So I think there's a collective vision that can be achieved through what it means to be a sort of 21st century public servant from whichever part of the system you're in.
Yeah, brilliant. Yeah, Alec, do you want to come in?
I was just going to add that I think what's really exciting is just building on the comments that have been made, which I completely agree with, is the shift I'm seeing very loud and clear, having been in NHS England for 8 months, and I don't think there's anything to do with me personally, that there's been quite a few announcements since I joined, but there is something about, there's a shift now towards the public and patients specifically, in terms of a focus now on providing a real customer service. Lots of us, let's not beat about the bush. Huge numbers of people of the 1.8 million workforce do an amazing job within the NHS. But we know that 11% of staff tell us they don't have the tools to be able to do that job. And 70% would say that the lack of interoperability makes integrated care really difficult. Integrated, holistic person care requires integrated information, and we don't have that. So that's a challenge. I think we've got to recognize and call out that we do have a burnt out workforce. We have a burnt out society. And I think that was the case before the pandemic, personally. We then had the pandemic. I don't really need to say more than that. But I think there is a shift. I'm really excited, leaving aside the 3 words that define it, of single patient record. I think it's the vision behind it that's really clear, as is the vision around the NHS app. And that is really building our systems of care around the individual, making it about their information, their data that they can give access to, and advocacy to where they can't manage their own health and care, so that we are shifting that focus. And we're shifting that focus towards the Amazon model. Amazon, as I said, my son has got his charger. It's arrived. He's messaged me to say thank you. I ordered it less than 24 hours ago. And yet, if I try and get a prescription, it's going to take me 2 or 3 weeks. And that's if I'm lucky. So that's the difference in that customer service. We've got to learn from industry. And then finally, you talked about trust. I define trust as being made up of 3 things: authenticity, making sure that whoever you are, when you're doing things, you can be as authentic and true to yourself and hold steadfast to the values, irrespective of the culture you may be working in. Secondly, that there's logic in decision making, which you can share and that you can be evaluated on. And thirdly, that we are compassionate. We need to get back to compassionate leadership, compassionate societies which exist, compassionate communities doing huge amounts across the country. But we've got to scale this up, because just picking up on Minal, amazing stuff happening in neighborhood, but we've got to get adoption, scale and spread. This has to be business as usual and a reimagined health and care system, rather than just having pockets of greatness happening in variability, which is just further perpetuating unwarranted variation. So it is absolutely back to leadership, but I think there's something about, there's a shift, and that mindset shift, I think, is coming from the centre, and that's to be welcomed.
Interesting. Thank you, Nico. What do you think?
Well, Kirsten very nicely stole my thunder. Thank you very much, with purpose-led leadership. So I'm not going to add to it. I'm just going to give it with an example of the things that I know when I work with. So if the leadership of an organization, if the leadership of a group of people, of leadership of patients comes with a certain mindset, then that transpires to the whole organization. Alec said there is a lot of great people in NHS, and I agree. Now, the last years, this has been managed through a mindset of cost containment. Therefore, these great people will focus on how can I contain cost. If the purpose becomes how do we create value for patients, how do we ensure that every patient gets what she or he needs, then that mindset will transpire through the whole organization. And I'll give one real example of what I said before. If your daughter is 23 years old, I have one in mind, and has myasthenia gravis. It's a disease that hopefully you don't know. I sincerely hope you don't know it. It's not an ultra rare disease, but it's also not a very prevalent disease. 15,000 people in the UK have the disease. Well, if you happen to be born in Germany, and I'll come with a list of countries, there is multiple medications that are on the market, available, and can be prescribed. If you're here, you can't. But we successfully contained costs. We're not spending money on it, right? Now you think Germany is a great country. So the following countries have medications for, multiple medications for this disease: Germany, Italy, France, Spain, Netherlands, Belgium, Luxembourg, Bulgaria, right? And so I think that purpose-led leadership is a shift from we've successfully managed costs into we've created a great life where people that suffer from unfortunately severe diseases can actually still do the things that they want to do. And ultimately, by the way, and that's where the hospital to community shift will come in, ultimately, those people will no longer need to go to a hospital because people like you can simply prescribe the routine medication because the medication has become routine after a while, which as a chronic disease expert, you will know much more.
It's really interesting, and it's always useful to get an insight from, especially putting something into an international context always hits something home. So let's go open up to the audience for questions. Does anyone have any questions for this excellent panel? I can see Adrian put his hand up at the back. We could have a...
Thank you. A question really for both Kirsten and Alec, fundamentally about making sure that we get data available to those who need it. And you talked about the questions about analytical capability. For any organisation that wants to get data out of NHS England in a meaningful way, it is almost impossible. And it's, for instance, as a college, we have about 24 monthly Freedom of Information requests that we send to NHS England. If you're doing a research project, it can take over 18 months to get meaningful data out, by which time your funding has run out. How could we actually deregulate all that data, open up the secure data environments to more people so that actually people can go and look around and improve their own services? The people who are actually submitting the data, having control of the data to actually improve things.
So to go first. Well, Adrian and I had the pleasure of meeting online, so good to see you in person, Adrian, and I'll catch up outside because I have promised you I'll sort this out, but I've only had 10 days since we spoke, so bear with me. So I think it comes back to, if we're going to reimagine health and care delivery, we've got to reimagine the operating model. We've been talking about it. We've got the 3 shifts and other enablers and reimagining that digital and data architecture. But at the core of that interaction between somebody and how we collect high quality, continuous, reliable data, we've got to then use that data. We need to measure data quality, something we don't do, and then we need to use it. We need to become the world's largest socialized, integrated, personalized, digitally enabled, but data-driven learning health and care system. And if science and technology is truly going to improve and enhance people's lives, then we absolutely, if we're measuring it, we need to make sure it's good quality, but we then need to use it. So, and we need to be able to use it real time to make those necessary changes. So I'm completely with Adrian, and I'll look into the mechanisms behind that, but we absolutely need to adhere to and be driven by digital to become that learning health and care system.
Definitely. Kirsten, do you want to come in?
I mean, there are going to be people in the room that know a lot more about data and digital than I do. I think my perspectives are that I think that ICBs have had actually huge strides in population health management and data. And I think there's some exemplars across London, Northwest London in particular, has, you know, really put a lot of time and effort and expertise. I don't think it's just around NHS data. I think if we're looking at maximising health intelligence and epidemiological approaches, we have to be able to have a unique identifier that works across housing and other data sets. For us, we're really interested in how we can look at housing tenure as predictors of health and social care needs, and also debt profiles, because actually we're looking at future vulnerabilities of people who may not be even engaging in healthcare services yet, would have very high levels of need. So I think there's absolutely around NHS data, but I think it's also about linking to other data sets. I mean, the sort of the availability of data is not the issue, it's just how we're going to get there. And I also think we have to have citizen conversations about data. I mean, patients expect the NHS to share data, you know, whether you're going to maternity or primary care. I don't think we've had enough conversations about what their expectations or feelings and thoughts, and I think it's quite emotive issues around how we use other data sets to look at their predictive health and social care needs. And I think we have to have those conversations. You know, it's really about trust, and I think that's around declining levels of trust in how we are using data, not just public sector, but how data is used. Declining trust, I think, in some public institutions, and I think we have to start having those conversations now, because the technology will just outpace our sort of collective willingness to be able to utilize it.
I think the one thing I would add, and this has really come from lots of the places that I've been meeting, is that one of the barriers is around the actual data sharing and the information governance. And there's a real challenge around, I mean, many of you will have heard the Section 251 and the effort that is required to be able to not just use data for population health management, but to then re-identify that data to identify who the actual people are that you need to, do something differently around. I think the second thing, though, is that, and Alec, you mentioned it already, is that the technology already exists. So a lot of these places are using what I would describe as middleware. So platforms or technology solutions that sit on top of whatever electronic patient record you're using in the NHS and social care, and the voluntary sector also picking it up. And it essentially it's the group of people that you are collectively supporting through that multi-agency working through neighbourhood health. Everybody has visibility. It's open data unless it's confidential, and everybody has visibility of who is seeing who, when, the touch points, because the ridiculous nature of the system we're in at the moment is that I can have people who have 6 people come and visit them in one day, all doing like tiny different bits of their health and care, instead of consolidating and rationalizing and using our workforce in a much more effective manner. So this starts to enable you to do so. It also starts to enable my district nursing team to say, oh, actually, Minal, I need you to do something for this patient in the next 2 days. And they can just task me. There's like a board that they pin the patient to. And I know that's my board for 48 hours. That's my board for 24 hours. And it starts to make it much more seamless. So we're not just connected as a team through our face-to-face interactions, but we are truly digitally connected. And it's really helped us to optimize care. So where we're starting to see these solutions already developing, I think the next step for us is to think about, well, okay, how do we spread them? How do we ensure that others are aware of them and then are able to either procure them or whatever easily?
Great, that's really interesting. Kirsten, can I just come in very quickly on what you said? Now, this might be a stupid question, but in the interest of kind of self-educating health policy people, you talk about getting data sets from wider, wider health determinants. If you did have and could deploy data, on debt levels, for example, what kind of interventions can a local government make or the NHS make together or individually?
Well, I can give you an example of what we're doing in Camden. So we are very interested in child poverty and low birth weight. It's one of our key priorities from public health. So we have looked at income data, and we offer a £500 grant for expectant mothers on any qualifying benefit. Now, we have that data access, and we proactively reach out to that population to give them £500. Now, £500 has they can spend it on what they want, and actually there's lots of evidence to show that cash transfers in pregnancy significantly improve outcomes. They don't have to have it into a bank account. They can come and get it as cash, because we know that it can get eaten up by overdrafts. So they're the kind of sort of bread and butter public health interventions that you can do with different types of data. Lots of those women actually were late bookers. So actually we have now added on, support for booking into, for midwifery services, smoking cessation, specialist drug and alcohol services. So it's looking at the system, it's the same populations, you're just looking at them through different lenses.
It's really interesting. It's great to hear what councils are doing. I think we'll come for one more round of questions if anybody else has got any more questions. If not, I will abuse my chair privileges once more. Oh, there's one over here. Oh, sorry.
So Debbie Frost, I work for NHS England, but I'm a GP by background. I've recently, I think anecdotal stories are usually quite powerful, as you've talked about. My mother's 90, and we've got various different records that we look at. It's very difficult, me accessing those from my home. She said to me that actually having a daughter who's a doctor, navigating the system helps. But I think there needs to be lots of education about the NHS app. She'll go on it, but she can't find it, so I've got to go on it, and My Care and Epic, and there's all these other things. And I wondered what the panel had to we're going to bring all these innovations, but if the elderly particularly can't use them, are there any key points to that, please?
That's a really good question. Who wants to come in first? Alec?
I'm happy to. Great question. And as I said, I think earlier, I think we need to invest in people, and that people is not just the workforce. Let's be honest, the workforce does not use the technology in front of them in a consistent, unvaried fashion, which is why we've got poor quality data. So we've got to get consistent use of what we've already invested in and invest in people from the workforce perspective, but equally we've got to do that for the public and patients and by advocacy. So I think the exciting bit about the concept and the vision for the single patient record is enabling somebody to have access to and contribute to in a meaningful real-time way all of their information, but pass advocacy for being able to access that information whenever they want to whomever they want to, so that they start to control it. We've got to shift, I think, the dial. This may be controversial, but I don't think GP should be data controllers. We need to remove that. If legislature needs to change, we should be doing that. Minister said we should be brave and bold, and I think now is the time. We've got a seismic generational shift. Technology exists. Let's put this information and data in the hands of people, the public, as well as patients, because that's the dial. We've got to keep people healthy and well so they don't become a patient. So for me, it's about a personalized health record where everything's in one place, where my Whoop data, my Apple data, anything I want is there. But if I become a patient, I can then both access, but also navigate and be triaged for self-care and access as appropriate, to avoid having to go and see Minal and neighbourhood teams if it's appropriate, or be signposted to the right place at the right time. So I think 70% of the population will be able to do that if we gave them the ability. That's the vision. But that, importantly, shifts the focus of the workforce on the 30%, and in particular the top 5%, who will be the really complex multi-morbidity people with wider social determinants impacting on their lived experience of chronic disease, where we then redeploy that workforce without having to increase the workforce numbers.
Great, thank you. Does anyone else on the punch, do you want to come in, Nico? No? Was there any more questions? Did a hand go up? Oh, yes, sure, go ahead.
Thank you very much. And Minal, really look forward to catching up about some of the radical place stuff going on in your very area. But I just put a note of skepticism, Neil Nerva, Councillor in Brent, about digital access. I love my NHS personal record. I think it's brilliant, yeah? But not everyone has access or understand or appreciates in the same way how it can be used. I take your point completely, Alec, about realigning and realigning resources, yeah? But simply, what can we do to enable more people to be digitally confident and digitally enabled now, so that we don't end up recreating inequalities in which we've got a group of people who actually are even better off because they've actually got that control over their lives, and they can use all the whiz systems which the NHS is setting up as it goes digital, without actually addressing some of the really difficult inequality issues which could be actually made worse, not improved. And how can we guarantee, and how do we guarantee that money stays in the system then, Alec, yeah, to actually do that extra work which you're talking about? A note of skepticism, not negativity, but challenge really, rather than skepticism.
Thank you. Yeah, who wants to come in first?
I think what we need to appreciate, which is kind of what you're saying, is the diversity of all different people. If I look, I have two daughters. If I look at how they look at data, if I look at my mother who's 84 and she looks at data, it's a different world. Yeah. However, if you don't fix the data availability for those that are able to handle it, you will never actually create freedom for the, you said 30%, I don't know what the number is, but for the percentage that can't be there. Then the second thing is, I think that's how I would love to link it back to the theme of the panel, which is hospital to community. You've talked about personalized care, about what do patients expect. You talked about actual people behind it. I think the strength of a community service, the strength of people working close to patients and to people, is that they know who is the 30% and that they know who is the 5%. And then GPs or other local care people can actually use the data to do the same thing as Insta does for my daughter, but then the GP does it for that patient that needs it in a different way or cannot access it because of financial burden or cannot access it for other reasons. So I think you need the 80%, 70%, 90% to fix the 5-10%.
Great. Alec, what do you think?
Well, I think in addition to, and there's too many acronyms, but the R's roles, all of those who are out in the community, podiatrists, dietitians, pharmacists, etc., and capitalizing on those opportunities, you mentioned this earlier, and the voluntary community faith social enterprise sector, I think we need to be getting learning more and getting involvement from commercial and industry, as well as academia, in terms of we've got to evaluate and measure everything we're doing to make sure we are learning from what works and what doesn't. So the example of that would be how do we use telecommunications? How do we get, if you need to buy a new phone, you go to Curry's or John Lewis or an Apple shop or wherever, an O2 shop, others exist. And you get advice, you get trained, you have a 5-minute preceptorship on digital skills as you're buying it. You get, my son said, why aren't we just making the NHS app something that just downloads automatically in the UK when you buy a new device? So that just becomes part of the onboarding. If it's been quoted, I'll reference, please, if it happens. It's my son who came up with that idea. So I think there's ways and means. We've just got to think, as I've said before, Amazon have cracked this, Ocado have cracked this, IKEA have cracked this. And yet when you look geographically between Stratford-upon-Avon, where I'm privileged to live, and Rugby in the northeast, there is no pharmacy in the community that serves Warwick, Leamington, 30-mile radius. No pharmacy stocks end-of-life care drugs for the 4 anticipatory events in terms of pain, nausea, secretions, anxiety. What happens? Either you get staff, district nurses driving around the community looking for pharmacy, and they handwrite prescriptions to enable this to happen, because you only send one electronic prescription to a pharmacy of choice in the community. Or secondly, family members do it. And repeatedly, family members are driving around the countryside. I'm sure this happens up and down the country when their loved ones die. That's the reality. So we should crack this. There are 7 wholesalers for drugs. And whilst there may be 22,000 drugs, actually in reality, in practice, there's only a couple of hundred drugs that we're using. How did Amazon do it? And we haven't cracked that within healthcare. So we need to learn from industry and apply those standards and start to actually galvanize their support. Because when the economy does well, the NHS does well, and vice versa. If we have a healthier society, we'll have healthier lives. But this requires a new social intervention and so I think interaction where we do it for the common good.
Thanks, Alec. And now I'll give you 1 minute to come back on that, and then we'll have to draw it to a close.
Yeah, I think the neighbourhood model is actually a really great opportunity to really drive forwards on digital inclusion, because, again, it's based on those trusted relationships. Actually, most people don't want to be digitally included so they can use the NHS app. There's online poverty is a real thing, electricity bills, holidays, insurance, job prospects. That's where they start from. But actually, how do we join up then all of the multi-agency services? So while they are being enabled and supported to become more digitally enabled for every other aspect of their life, health is included. And there are community health and wellbeing workers that have been embedded in Cornwall, in Westminster, in parts of the north of England. And essentially, they have been allocated the 20% most deprived households in a neighbourhood or a geography or a place. They go and knock on those individual household doors. It's now 5 knocks till somebody lets them in. They start to build those relationships. They start off with their housing or their plumbing or their kids and education, but they build those relationships then back around health. And I think that's a great opportunity to identify who is digitally excluded, because we don't code it, so we don't actually know, and then to be able to then have more targeted interventions to support them.
Completely agree, and that also happened to be one of our recommendations on our recent papers on primary care. So I would just like to thank our absolutely excellent panel on a not straightforward subject. So thank you so much for your time and for your insights. So if we could just thank the panel